Hello, everybody. Over the next few minutes, we will discuss the evidence for the use of the MRI pathway for the detection of prostate cancer. Here are my disclosures. Now, we should all be familiar that the MRI pathway is able to deliver 4 key benefits compared to systematic biopsy. Number 1, it reduces the number of patients undergoing biopsy. Number 2, it reduces the diagnoses of indolent cancers. And these, in fact, are the 2 main benefits. Another benefit is there's a greater precision of tumor grade and tumor volume determinations for most patients. And it also increases the detection of clinically significant cancers, mostly for patients who have had a prior negative biopsy. Let me show you a randomized control study that was published recently, where patients were randomized to systematic biopsy or an MRI targeted biopsy when the MRI was positive. If you look at the findings on the right hand side, you'll see that 37% of men avoided a biopsy. You'll also notice that there was a 50% reduction in the number of men diagnosed with indolent disease. But there you can see that there is only a small improvement in the detection of clinically significant disease. And this study merely confirms what we know from a meta-analysis where the systematic biopsies were compared to the MRI pathway. And the MRI pathway consists of no biopsies for PI-RADS 1 and 2 cases and MRI-directed biopsies to the target alone for PI-RADS 3 to 5 categories. And you can see the benefits on the right-hand side. 33% on average avoid a biopsy. There is about a 10% absolute reduction in the diagnosis of indolent disease, but you'll see that the MRI pathway does not impair the detection of clinically significant cancer. So if you had a mixed outpatient population where 3 in 10 men have clinically significant cancer, if you were to do a systematic biopsy, you would miss 111 of the 300 clinically significant cancers that were there, and 20% of those would be Gleason grade 3 or above. 700 men would be diagnosed as having either benign disease or indolent disease, but only after they had experienced a biopsy. On the other hand, if you were just to use the MRI pathway, remember the MRI pathway is no biopsy for negative cases and a targeted biopsy alone in positive cases, you would miss fewer cases, 84, and most of these would be Gleason grade group 2. You would correctly diagnose insignificant disease or benign disease in 672, with only 28 men needing a biopsy to confirm the absence of significant disease. So we can see that MRI is more likely to make a correct diagnosis using fewer biopsies in a mixed cohort of patients. And in fact, you can notice that the greatest benefit is in patients who have a prior negative biopsy. But there are a number of things we need to ask. Do all men benefit from the MRI pathway? How do MRI results change the risk of there being a clinically significant cancer present? Can we modify the risk using PSA density before deciding on the need for biopsy? How are biopsy methods altered by the fact that you now have a roadmap? And what do you do when no cancer is found by the MRI or the MRI-directed biopsy, yet clinical suspicion remains high? So the first question is, do all men benefit from the MRI pathway? Well, it's not entirely clear from the literature because there have always been restricted inclusion criteria for most studies. In fact, very few studies have looked at benefits by clinical inclusion criteria apart from looking at whether patients were biopsy naive or whether they had prior negative biopsies. And when you look at the guidelines, you'll also see that there is inconsistency. So the EAU guidelines say all men should have an MRI prior to a biopsy, whereas the NCCN guidelines say that it should only be prior negative biopsy men. So the question we really have to ask is, if you're not going to do a biopsy, do you not do an MRI? This question remains unanswered. So let's take a man who has a very elevated PSA and a normal DRE. Now, in this man, you can clearly see metastatic disease to the bone marrow. You can see nodes in the left pelvic side wall. You can see a locally advanced prostate cancer. So what then is the benefit of the dynamic contrast enhancement? When we look at the EAU guidelines, you can see the EAU guidelines recommend the use of MRI when patients have an elevated PSA with a normal DRE. And this is on the back of evidence such as this, where you can see that the people who get the most benefit from the use of MRI are people with a negative DRE, regardless of the PSA. So let's take a case-based approach to understanding the role of MRI in biopsy-naive men. Let's take an example of a man who is 58 years old, has an elevated PSA, and has a DRE that's positive on the right side. Would you do a systematic biopsy on him straight away, or would you recommend doing an MRI and then deciding thereafter? Well, the EU guidelines makes no specific recommendation on the need for additional testing when the DRE is positive. So we did an MRI scan, and you'll notice that he's got capsular retraction in the left peripheral zone, and the right peripheral zone, which is where he was abnormal, in fact is entirely normal. This is a PI-RADS 2 case. So now would you advise systematic biopsy? Remember, the risk calculator suggested that the prevalence of clinically significant cancer is likely to be about 13%. So he should have a systematic biopsy in the absence of a focal detectable lesion. Or would you not do a biopsy because the MRI indicates that there is no underlying clinically significant disease? In other words, you would refer him for urological follow-up. Do you need to know more about what the yields of systematic biopsies would be in a negative patient? Or would you like advice about what to do regarding clinically significant disease in negative cases? Well, if you took 100 men with a negative MRI and you did systematic biopsies, you would find that 74 men would have no cancer detected. In other words, 3/4 of these men would undergo an unnecessary biopsy with their attendant side effects. In fact, you'd find that 18 men would be overdiagnosed with indolent cancers and therefore would be exposed to the long-term costs of active surveillance. However, you would detect 8 men in whom you would correctly diagnose a clinically significant cancer, and these 8 men would then receive the appropriate therapy. Another way to look at this is to say that you would need to biopsy 12 to 13 men with a negative MRI to detect one clinically important cancer. In other words, 8 out of 100. However, not doing a biopsy after a negative MRI would result in 3 men with potentially Gleason grade group 3 disease not being detected. So how do you deal with the fact that these 3 men would go undetected? Well, there's a couple of strategies you could use. you could, one, initiate a safety net of monitoring, and number two, look at the PSA density. Here is a meta-analysis that's recently published looking at men with negative, indeterminate, and positive MRI scans and the likely prevalence of clinically significant disease. You can see that men with negative scans most likely to have clinically significant disease are those men with higher PSA densities. So if you have a negative MRI and you have a higher PSA density, you should consider doing systematic biopsies on these patients. And what do the guidelines say? The EAU guidelines say that when an MRI is negative and clinical suspicion is low, omit a biopsy based on shared decision making. However, for patients who have had a prior negative biopsy and the clinical suspicion remains high, then these patients will need a systematic biopsy based on shared decision making with the patient. The PI-RADS committee echo these recommendations. A TRUSH biopsy should only be undertaken if the patient is high risk. If the patient is not high risk, no immediate monitoring is required. Safety net monitoring is needed according to the roles and responsibilities defined by the multidisciplinary teams. Next, let's discuss a man who has a positive MRI. This 55-year-old man has a slightly elevated PSA, but you can see that he's got extracapsular disease with a PI-RADS 5 lesion in the left peripheral zone. What sort of biopsy should we perform? Should we have systematic cores alone, targeted cores alone, systematic and targeted cores? Should we do a focal saturation biopsy, or do we need to look at the guidelines to see what they recommend? If you look at the EAU guidelines, they recommend that when an MRI is positive in a biopsy-naive man, you should perform systematic and targeted biopsy cores. However, if you've had prior negative systematic biopsies, then you only need to perform targeted biopsy cores. So what are the trade-offs between a targeted biopsy course to a lesion like this versus targeted and a systematic biopsy course? Well, if you took 100 men with a positive MRI and you did a targeted biopsy course alone, you would detect 39 important cancers. This increases to 43 men if you combine systematic and targeted biopsy cores. Targeted cores alone would detect 16 indolent cancers. However, if you added a systematic biopsy, you would detect 4 additional indolent cancers. And this is therefore the trade-off. For every man with clinically significant cancers gaining benefit from a combined targeted and systematic biopsy cause, you would detect 1 man with clinically insignificant cancer who would gain no benefit, just the harms of active surveillance and of over-treatments. So why do targeted biopsies miss clinically significant disease? Multiple studies show that the absence of clinically significant cancers after a targeted biopsy are often due to targeting errors. Indeed, it's found that clinically significant cancers are found in sextants adjacent to MRI targets. And we now know that sampling normal appearing, non-adjacent sectors does not alter the stratification in the majority of patients. We know that focal saturation biopsies around an MRI target increases the yields of clinically significant disease without affecting overdiagnosis rates. What we don't know is what are the optimal number and framing of the cores for each suspicious lesion. And it may be that we need to use fewer cores around larger lesions and more cores for diffuse lesions, heterogeneous lesions, PI-RADS 3 lesions, for smaller lesions and when multiple lesions are present. So what does the PI-RADS committee say? The PI-RADS committee agrees with the EAU guidelines that MRI targeted as well as systematic biopsy cores should be undertaken. However, it leaves the option open for focal saturation biopsies. And this is what happened to this man. He had focal saturation biopsies with a number of cores through the left side, which diagnosed a high-risk prostate cancer. From the previous discussions, it's quite clear that we're always trying to balance harms versus benefits when undertaking any biopsy strategy in positive and negative men, because we are trying to increase diagnosis of clinically significant cancers by using targeting. And at the same time, we're trying to reduce biopsy rates and reduce overdiagnosis by performing fewer systematic biopsies. Well, there's a number of ways we can adjust this further by, for example, changing the MRI thresholds for positive and negative cases, by combining MRI with PSA density, by employing alternative strategies for biopsy, by taking into account patient preferences. And we also need to get a handle on the uncertainties on the magnitude of the risks and the benefits. So up until now, we've implied that PI-RADS 1 and PI-RADS 2 cases are negative and PI-RADS 3, 4, and 5 are positive. And you can see how as the PI-RADS score increases, we notice an increase in the prevalence of clinically significant disease, particularly grade group 3. So MRI PI-RADS category is not only a diagnostic biomarker, but also potentially a prognostic biomarker. If we look at this graph more carefully, we can see that the prevalence of clinically significant disease in negative cases is 6%. That means that the negative predictive value of a MRI is 94%. These are all the positive cases, PI-RADS 3, PI-RADS 4, and PI-RADS 5. Looking at these cases, you can see that the false positive rate in PI-RADS 3 cases is 89%. The false positive cases in PI-RADS 4 cases is about 50%. And the false positive cases in PI-RADS 5 is about 28%. So what stops us changing the negative positive threshold to PI-RADS 1 to 3 and 4 and 5 respectively? And what would be the benefits of doing so? If we use PI-RADS 3 to 5 for positive disease, we know that this is best suited for symptomatic or secondary screening due to the intrinsic high prevalence of clinically significant cancers, which we know is between 30 and 50%. We know this is less well correlated with clinically significant cancers, but there is a high sensitivity, but a lower specificity. In other words, you're going to get more false positives. So you end up doing more biopsies, and there is a higher rate of grade 1 cancer detection. On the other hand, there are less false negatives. So it seems to be very suitable for prior negative biopsy patients. But we will have to employ PSA density adjustments, as we will discuss next. On the other hand, if we use PI-RADS 4 and 5, this is best suited for lower prevalence situations, such as primary screening, where the prevalence is going to be 4 or 5%. This we know is going to be better correlated with not only Gleason group 2 disease, but also 3 and above. And it results in a better balance between sensitivity and specificity. There will be less false positives, so in other words, less biopsies and lower rates of indolent cancer detection. But of course, there will be false negatives. In other words, you won't pick up the cancers in the PI-RADS 3 category. And oftentimes, if you were to use PI-RADS 4 and 5, you wouldn't have to make an adjustment using PSA density. So how does adjusting PSA density help us in deciding who does or does not need a biopsy? We've seen this graph already. You can see that if you have a PI-RADS negative patient, then those with the highest PSA density, in this particular instance, 0.2 and above, will have a more than a 10% chance of having clinically significant disease. So these men should get biopsy. However, for intermediate cases, PI-RADS 3 categories, you can see that anybody with a PSA density threshold of 0.1 and above should get a biopsy because there is a greater than 10% chance of there being clinically significant cancers. And of course, all men with PI-RADS 4 and 5 should get a biopsy. So if you were to limit yourself to only positive men, in other words, PI-RADS 3 to 5, you'll see that 38% of men will avoid a biopsy and you will miss about 6% of cancers. If you were to restrict yourself to PI-RADS 4 and 5, you'll see that 10% more men would be able to avoid a biopsy, from 38 to 49% now, but you will have missed more clinically significant cancers. However, if you were to biopsy these men here, you'll see that 38% of men will avoid a biopsy, but the number of men in whom you missed a clinically significant cancer is only 5%. In other words, less than this 10% threshold. Looking at these figures carefully, you'll see that the same number of men avoid a biopsy, whether you biopsy men with PI-RADS 3 to 5 or you use this more complex scheme. So here you'll see that 6% of cancers are missed, here 5% are missed, here 38% avoid a biopsy, and here 38% of biopsies are avoided. But you can see the figures are in fact slightly different. These men here are more appropriately biopsied because PI-RADS 1 and 2 cases with only a high PSA density are biopsied. Similarly, indeterminate cases with a higher PSA density are biopsied. So these are more appropriately biopsied, although the number of missed cancers is in fact identical. Now, so far we've talked about systematic biopsies and compare that with the MRI pathway. Remember the MRI pathway, negative cases get no biopsies and positive cases only get an MRI targeted biopsy. Of course, there are other schemes which you can follow. So for example, in the detection focus pathway, which is along here, negative scans get a systematic biopsy and positive scans get both a systematic and an MRI-directed biopsy. And this is often preferred by urologists. The MRI focus pathway compensates for missed cancers by the MRI targeted biopsies by adding a systematic biopsy. And of course, this is what we've been talking about so far and is preferred by the EAU. In other words, negative cases are getting no biopsies, positive cases are getting both an MRI-directed biopsy as well as a systematic biopsy. So what is the value of a targeted biopsy to the systematic pathway? Well, it turns out it's about 6%. And what is the value of a systematic biopsy to men who have a MRI positive case? It is 4%. So in fact, there are a number of different pathways, the conventional pathway being systematic biopsy, the MRI pathway is here, the MRI focus pathway is here, which balance the harms versus the benefits. And we've already discussed a number of these today. But we also need to take into account the care priorities for men who are suspected of having clinically significant cancer. We said that if you have a typical man, the typical risk threshold for biopsy would be about a 10% chance of having clinically significant disease. Of course, you can have men who are biopsy averse. These are lower risk men in the situation of screening, for example. Here you should apply a much higher risk threshold because you want to minimize overdiagnosis and you want to minimize false positive results. The idea is to reduce overtreatments and therapy-related harms because we know there's only minimal benefits for the active treatment of indolent cancers. On the other hand, we'll have patients who are cancer averse. These are patients with a family history, for example. Those men who are at persistent suspicion after a prior negative biopsy or a negative MRI. And for these men, we should lower the risk threshold to about 5%. The idea is to detect clinically significant cancers because we are less concerned about false positive results. And the idea here is to increase the cure rates of men with important disease. The last thing we should discuss is the variability of the benefits of the MRI pathway. Remember, we said that there are two major benefits. One, reduction in the number of patients undergoing a biopsy, and number two, reduced diagnosis of indolent cancers. And this is due to the negative predictive value of MRI. There's also a greater precision of tumor risk stratification in most patients, and there's an increased detection of clinically significant disease in some patients, mostly prior negative biopsy patients. And this relates to the positive predictive value of MRI. Now, what is the negative predictive value variance and what is the positive predictive value variance? Well, it turns out that the negative predictive value of MRI is very high and has low variability. The positive predictive value variance is very inconstant and highly variable. So here are the negative predictive value in 8 centers. You can see on the right hand side that the negative predictive value on average was 88%. But across the center sample, you can see the negative predictive value is actually very good and quite constant between different centers. So high negative predictive value with low variability means there's a consistency in biopsy avoidance. Now let's look at the positive predictive value. You can see this is the positive predictive value taking a level of 4 and above for a targeted biopsy alone in 26 centers. You can see that the positive predictive value variability ranges from 25% to 75%. This is a huge variation. So although this is the average, you can see the actual variability is quite large. So there's an inconstant positive predictive value with a high variability leading to inconsistent biopsy results. So here are the 5 golden rules for the use of MRI for prostate cancer diagnosis. Only use MRI for men who are likely to derive benefit from the comprehensive approach. You need to carefully assess the risk of clinically significant disease using PSA, PSA density, risk calculators, family history before and after you have the MRI result. Do not offer an immediate biopsy if the MRI is negative unless high risk factors are present. You need to accept that not all significant cancers will be found immediately, and you need to have robust safety nets for negative cases not undergoing a biopsy and for positive cases who have a negative biopsy. All the time, you need to ensure that the MRI-directed biopsy method that you use minimizes overdiagnoses, improves risk stratification, and ultimately directs the management of your patients. Thank you very much for listening.